Bismillahir Rahmanir Rahim. So today we are going to discuss the same paper and resuming from where we left yesterday. Well, yesterday we did page number 214. Well, I'm Dr. Jangin. I'm going to do the SK 10 series, and this is the first paper, that is the medicine, and we have covered the maximum portion yesterday, but there was a little confusion. So we have done the page number 214. This page was done. Then we did the 215. Then we did the page 216, and then the 217 was skipped. This is 218. So we will come toward those MCQs first. So this is page number 217. So starting with this MCQ. So you look at the page and MCQ number and compile all the thing in a normal pattern. So starting with this, what will be normal in a restrictive lung disease? So if we are having FEV1 less than 70%, if we see is less than 70%, guidelines are less than 70%, and FEV1 by FVC, that is less than 70%. This is obstructive disease. You look for the COPD, you look for the asthma, you look for the bronchiectasis. This is obstructive disease. Well, in restrictive disease, this hold true. FE1 कम होगा, FVC भी कम होगा, लेकिन FE1 by FVC ये ज़्यादा होगा, ये नॉर्मल होगा, ये चीज़ नॉर्मल होगी. तो यहाँ पे क्वेश्चन में क्या पूछ रहे हैं कि what will be normal in restrictive lung disease? The answer is FEV1 by FVC, it will be normal. Vital capacity goes down, FRC almost goes down, lung compliance goes down. In obstructive disease, lung compliance increases. Normal breathing? No, there is no normal breathing. There is abnormal breathing due to hypoxemia. So answer C is right over here. Now the penile erection is caused by, we already know this is parasympathetic. And in parasympathetic we are having muscarinic cholinergic. In parasympathetic we are having muscarinic cholinergic. Simple. But they will confuse you. Sympathetic cholinergic are present where? Sympathetic cholinergic. One is sympathetic and other is cholinergic. Mainly the sweat glands. So the sweat gland, they are sympathetic, but they have acetylcholine. Coming next, pancreatitis with fluid. Now this is actually a topic of interest. Pancreatitis. There are two types of necrosis in pancreatitis. One is the fat necrosis and the other is liquefactive necrosis. Liquefactive mean if there is necrosis in the parenchyma. Fat mean outside the parenchyma. And which one is more common? Fat. Now over here the MCQ is saying what? Fluid in the peritoneum. Peritoneum is of course fats. And fluid is the pancreatic fluid, such as amylase, lipase, so there causes necrosis of this fat. So this is simply fat necrosis. If a question says in a pancreas there is a focus and which is a necrosis, this focus is what? This is liquefactive necrosis, because this infection is in the parenchyma and this is usually liquefactive. And liquefactive is already seen in the brain. They will always confuse you, because usually in the solid organ you are having coagulative necrosis, but in the brain you are having liquefactive necrosis. Coming next, girl from poor family presented with a frontal bossing and leg bowing. Of course, the signs of rickets. So vitamin D deficiency. Vitamin D deficiency before puberty causes rickets. After puberty, it causes what? Osteomalacia. Next, Maximum cross-sectional area is for capillaries. If you combine all the capillaries and hold it like this, so there will be maximum cross-sectional area. Well, the minimum cross-sectional area is for aorta. Because it is single, it has minimum. Inability to convert glyoxylate to which amino acid leads to renal stone? The glyoxylate usually convert into glycine. So if this is inhibited, what happens? This concentration increases, and we know that when oxalate increases in urine, it causes what? Oxalate stone. A typical neuron feature axon helix between soma and axon. This is the statement. Patient has to go through operation and normal antiemetic is not working. Which antiemetic will you give? Now, anesthesia related vomiting. Anesthesia related vomiting, you have to give unset. You have to give unset. And if there is no control even with the onset, then you are supposed to give Aprion, either in a tablet form or capsule, and this is in routine practice usually seen in chemotherapy, but this is preserved for chemotherapy. Next, which hormone will be in normal level during pregnancy? In normal level are decreased level, so the growth hormone, because its action is taken by human placental lactogen. And there is another MCQ: the resistance to insulin is due to HPL, human placental lactogen, causing insulin resistance and hyperglycemia. And this is the factor for gestational diabetes mellitus. Gestational diabetes mellitus means after 20 weeks of gestation. If before 20 weeks of gestation, this is not gestational diabetes mellitus, because this hormone increases after 20 weeks. So it has got association with that. After 20, gestational. If before 20, not gestational. Similarly, if hypertension after 20 weeks, you can say gestational hypertension. Less than 20 weeks, it is not gestational hypertension. It is not gestational hypertension. So coming next, 41% hematocrit mean, that is erythrocytes, RBC. In polycythemia, where which of the following will be increased? Now, when you say the word polycythemia, it means increased RBC mass. Why not concentration? The reason is, if there is a dehydration, what happens? The water content goes down, but the hemoglobin content remains the same. So what you measure the hemoglobin in concentration, milligram per deciliter. So if your volume goes down, if your deciliter goes down, the blood volume goes down, there is a false elevation of HB and hematocrit. And you may have seen in the dengue patient, when there is the third space fluid shift, there is increase in hematocrit. That was not polycythemia. That was relative increase in RBC concentration. The RBC mass was the same, but concentration was increased. So in dehydration, you are having increased concentration, but in polycythemia, you must have increased RBC mass. Pregnant lady with bile duct obstruction, so the GGT, and if asked in which other condition GGT is very specific, the answer is pregnancy. Why not alkaline phosphatase? Because in pregnancy, the alkaline phosphatase comes from placenta. So that may be false positive elevation. Another is alcoholic. In alcoholic, the GGT goes up. Next, BP regulation is not maintaining which feedback mechanism is not working properly. Now the BP control is negative feedback. Now what is meant by negative feedback? Negative feedback means the increase in the outcome causes certain changes which causes the increase in the input. So if there is increase in BP, it activates certain responses, the output is decrease in BP. So this is negative feedback. What is positive feedback? The increase in one thing causing increase in the other thing. So this is positive feedback. Like the delivery of the baby, what happens when the head it stretches the cervix down? What happens? There are reflexes going upward, and the reflexes then causes further contraction of the uterus. So if there are more stretching, there will be more contraction. So the stretching is actually the input. So more input give more output. So this is positive feedback. Another example of positive feedback is the blood clotting. Whenever the activation of blood cascade, what happens? The thrombin and the prothrombin, they further activates clotting. This is another example of positive feedback. Hypertension control is the negative feedback. Down syndrome, most common cause is trisomy, that is 21 trisomy. Eaton-Lambert syndrome, autoantibodies are present in, that is voltage, that is the calcium channel. Let's suppose this is a neuron, this is the nerve ending, and this is the muscle, the skeletal muscle on which it is acting. Of course, you are having acetylcholine releasing from these nerve ending, but these acetylcholine are released whenever there is a calcium influx. Whenever the impulse reaches, what happens? Whenever the impulse reaches over here, what happens? The calcium channel open up. When the calcium channel open up, the calcium goes inside. When the calcium goes inside, the calcium combines with the acetylcholine vesicle and release of acetylcholine. So what happens in Eaton-Lambert syndrome? There are antibodies formation against these channels, and these are closed. When these channels are closed, when the impulse reaches over here, there is no influx of calcium. When there is no influx of calcium, there is no release of acetylcholine. This is presynaptic. This is presynaptic. And myasthenia gravis, there is postsynaptic. That is postsynaptic. And they will give MCQ. A patient is having weakness and that improved after exertion. So अगर किसी पेशेंट में वीकनेस है और वो इम्प्रूव कर गई है एक्सर्शन के साथ, तो वो क्या है? लम्बर्ट ईटन. क्यों? सपोज ये नर्व एंडिंग है, जब आप एक्सर्शन करते हो तो मोर एंड मोर एंड मोर एंड मोर स्टिमुलस जो है वो आते हैं. जब ज़्यादा स्टिमुलस बन जाते हैं तो दे काजेज दिस कैल्शियम चैनल टू पॉप अप. They causes the antibodies that are attached to this calcium. They cause the removal of these antibodies because of the strong impulses coming again and again. When these are removed, calcium then comes inside and release the acetylcholine, and the muscle strength is improved. What happened in the myasthenia gravis? That is the reverse phenomena. With exertion, there is the weakness gets worsened. With exertion, the weakness is increased. Why? Let's suppose this is skeletal muscle and you are having acetylcholine receptor over there. Now what happened in the myasthenia gravis? This is type 2 hypersensitivity reaction. This is another MCQ. The antibodies are made against these acetylcholine. So the antibodies are attached over there. When the antibodies are attached over there, now when the acetylcholine comes, can it combine with this? No, it cannot. Can it combine with this? No. Can it combine with that? No, because they are already occupied with these antibodies. But there are some receptors. There are some receptors to which these acetylcholine can bound. To which these acetylcholine can bound. To which these acetylcholine can bound. But whenever you repeatedly doing exertion, what happens? These acetylcholine store also finishes. The acetylcholine storage, the acetylcholine function, they further decreases. So the person weakness gets worsen. The person weakness gets worsen. तो क्या होता है? ये एंटीबॉडीज ये डिस्प्लेस हो सकते हैं जब एसिटाइलकोलिन बढ़ जाए. देयर इज़ अ कम्पिटिटिव इनहिबिशन. अगर रिसेप्टर ज़्यादा है तो एसिटाइलकोलिन इधर बैठेगा, ये नहीं कंबाइन नहीं करेगा. अगर रिसेप्टर पे एंटीबॉडीज ज़्यादा है, अगर एसिटाइलकोलिन कंसनट्रेशन ज़्यादा है तो ये इनके जो एंटीबॉडीज़ हैं इनको भगा देगा. बिकॉज देयर इज़ कम्पिटिटिव इनहिबिशन. कंपटीशन हो रही है, जिसकी कंसनट्रेशन ज़्यादा होगी वो जो है he will be responsible for the primary action. तो अगर एसिटाइलकोलिन हम किसी तरह बढ़ा दें तो क्या करेगा? ये एंटीबॉडीज़ को हटा देगा और वीकनेस इम्प्रूव होगी. एक्सरसाइज के साथ ये वर्सन इसलिए होती हैं क्योंकि ऑलरेडी आपके वो रिसेप्टर जो है वो किसी और चीज़ ने ऑक्यूपाई किए हैं और बहुत कम रिसेप्टर्स है आपके पास एक्शन के लिए. और वो भी फिर जो है आप एक्सरसाइज कर ले तो जो बहुत सारा जो छोटा एसिटाइलकोलिन था, जो थोड़ा बहुत एसिटाइलकोलिन था, वो भी ख़त्म हो जाती है. सो वी हैव टू इंक्रीज द एसिटाइलकोलिन concentration. If you are increasing the acetylcholine concentration, you are improving it. Now they will confuse you. A patient comes to you, diagnosed case of myasthenia gravis. Well, this is the diagnosed case, and the patient is already on medication. The patient is already on medication for myasthenia gravis. Now the patient is having weakness. So you give acetylcholine esterase inhibitor. एसिटाइलकोलिन एस्ट्रेज ये एंजाइम है जो एसिटाइलकोलिन को इनएक्टिव करता है. एसिटाइलकोलिन एस्ट्रेज वो एंजाइम है जो एसिटाइलकोलिन को इनहिबिट करता है. एसिटाइलकोलिन एस्ट्रेज इनहिबिटर जो है ये वो एंजाइम है जो आपका, ये वो ड्रग है जो आपका एसिटाइलकोलिन एस्ट्रेज को डैमेज करता है, तो आपका एसिटाइलकोलिन बढ़ जाता है. कंसेप्ट को पकड़ ले. पेशेंट आया है माइस्थीनिया ग्रेविस का. ये मैं इसलिए बता रहा हूँ क्योंकि वो इससे ज़्यादा कॉम्प्लिकेटेड एमसीक्यू एफसीपीएस पार्ट फर्स्ट में कोई एक्सपेक्ट नहीं कर सकता. माइस्थीनिया ग्रेविस का ऑलरेडी डायग्नोस्ड केस है और वो मेडिकेशन पे है, गुड कंप्लायंस टू ड्रग है. अभी उसको वीकनेस है और वो आपने एसिटाइलकोलिन एस्ट्रेज इनहिबिटर ड्रग दे दिया. एसिटाइलकोलिन एस्ट्रेज इनहिबिटर मीन कि आपने वो एंजाइम इनहिबिट किया जो नॉर्मली एसिटाइलकोलिन को डिस्ट्रॉय करता है. Acetylcholine esterase normally inhibit acetylcholine. Whenever you are giving acetylcholine esterase inhibitor, it means you have inhibit the enzyme which destroy acetylcholine. So it means the acetylcholine concentration would go up. So you give edrophonium, that is acetylcholine esterase inhibitor, and the person weakness got worsened. What is the diagnosis? Point number 1, myasthenia gravis crisis. Number 2, Korinergic crisis. Myasthenia gravis crisis or Korinergic crisis. Well, this is MCQ you have to answer. This is the MCQ you have to answer. The answer is Korinergic crisis. If the weakness is improved with edroponium, then this is myasthenia gravis crisis. Now, what is the mechanism of Korinergic crisis? When you give the drugs to the patient and there is increase in the acetylcholine level, what happens in the skeletal muscle? There are receptors. There are a lot of receptors. When you give more and more acetylcholine, there is down regulation of these receptors. The receptors, they down regulate. When the receptors down regulate, who will give message to the skeletal muscle to contract? No one. If this is your skeletal muscle, it contracts because there are messages going on. If you have down regulated the receptor, there is no message to the skeletal muscle, and that will lead to the weakness of the muscle. And this is actually down regulation of acetylcholine receptor, and this phenomena is called Korinergic crisis. What is the treatment? Decrease the dose of acetylcholine. Or in emergency you can give atropine. So that was just an MCQ. Changing of posture from supine to the standing position, what will increase? So from supine, this patient was lying. Now standing position, he goes to the standing position. What will increase? Now focus on each word on the stem. What will increase? If the person goes from this position to this, what will happen? Due to gravity, there is decreased venous return. Now focus on my each and every word. मेरी हर बात पे फोकस करें. ग्रेविटी की वजह से venous return decrease हो गई. Point number 1. Point number 2. If venous return decrease हो गई, तो blood flow to the heart is decreased. Blood flow to the right heart is decreased. If blood flow to the right heart is decreased, blood flow to the left atrium and left heart is decreased. If blood flow to the left heart is decreased according to the Frank-Starling law, if there is decreased blood coming, there will be decreased blood going out. There will be decreased stroke volume. If your stroke volume goes down, what will happen? Cardiac output is equal to stroke volume into heart rate. The stroke volume goes down. What happens? Your cardiac output also goes down. When the stroke volume goes down, the stretch receptor in the aorta, they are stimulated and they activate sympathetic system. So the heart rate is activated. The heart rate is increased to maintain this cardiac output. So your heart rate increases to maintain the cardiac output. Your stroke volume, it goes down. Your cardiac output, it goes down. And what happens to the venous compliance? Compliance mean reservoir. If compliance is increased, it means reservoir, the veins are in a relaxed position and there is reservoir. There is a lot of blood in it. After standing, immediately there is increase in compliance due to the gravity. But as a compensation, if the question asks, after compensation, what will happen? There will be sympathetic stimulation that will cause constriction of this vein, and then all the thing will be normalized. Over here, the heart rate is increased. All other things goes down. Well, do not confuse these postural changes with the breathing pattern. During deep inspiration, what will happen? That is another scenario that will come in the future MCQ. 8-year-old with 1 episode of high BP. Now, focus on this 1 episode of high BP and sleep disturbance. Whenever there is a sleep disturbance, there will be sympathetic stimulation, and whenever there is sympathetic stimulation, that will cause hypertension. So this is anxiety due to sleep disturbances. And we have seen whenever there is resistant hypertension and you give anxiolytic, BP actually goes down. So that was MCQ number 61. So the rest of MCQs from the 62, I think we have covered that in the previous lecture. We will come in a while to some of the MCQs on that page that were left yesterday. So coming next, tumor compressing interior surface of sternocleidomastoid. Now let's suppose this is your sternocleidomastoid muscle. It has got two ends. It has got two ends. This end, sternal end, and clavicular end. Superiorly, it is attached to the skull, and inferiorly, it is attached to the clavicle and the sternum. Now the external jugular vein, it moves like this, and the internal jugular vein, it moves on the posterior surface and then comes out between the two heads. Now the question is saying interior surface. From the interior surface, it will compress the external jugular vein. It will compress the external jugular vein. If the question says posterior surface, then it will compress the internal jugular vein. So over here the answer is external jugular vein. Over here the answer is external jugular vein. What should be given for immediate warfarin reversal? The answer is FFPs. The answer is FFPs. But before FFPs, if there is prothrombin concentrate complex, I will pick that. If there is not in the option, then I will choose the FFPs. So look for the prothrombin concentrate complex. Prothrombin concentrate complex. If that is in the option, that is the right answer. If that is not, then FFPs. If FFPs is there and FFPs plus vitamin K, I will pick FFPs because the question is saying immediate reversal. Vitamin K takes how much time? There is another MCQ. If you give vitamin K, how much time will it take for the reversal of the coagulation studies? The answer is 12 to 24 hours. Why? Because the vitamin K has no role on already clotting factors. It actually activates that enzyme that causes modification from the liver. So it will produce more clotting factors. 2, 7, 9, 10, and that takes this much time. A patient is taking cimetidine. Cimetidine is the in P450 enzyme inhibitor. P450 enzyme inhibitor. So develops already on warfarin, they develop increased bleeding time. Which of the following is true regarding action of cimetidine on warfarin? The answer is it decreases the clearance of warfarin from the liver. Normally, P450 system, it inhibits the warfarin. So if you give cimetidine, it actually prevents this conversion from the active to inactive form. So the warfarin, it remains in the active form in the blood for a very long time, and it will increase the INR further, and there is a risk of bleeding. Example of drug receptor interaction is atenolol, bradycardia. It directly attaches to the beta receptors on the SA node and the AV node and the myocardium. So on the SA node, it decreases the heart rate. On the AV node, it increases the PR interval. And on the myocardium, it decreases the contractility of the heart. So it decreases the cardiac output, decreases the heart rate, decreases the systolic BP. Regarding defecation reflex, rectoanal, if that is not, then parasympathetic reflex is the answer. Defecation reflex is initiated by now the word is initiated. The answer is mass movement. The answer is mass movement. Defecation reflex is initiated by a mass movement. If there is no mass, there will be no initiation of defecation reflex. It is carried out by rectoanal. If that is not in the option, then parasympathetic. It is parasympathetic reflex. It is parasympathetic reflex, and it is controlled by vagus nerve, or is 2, is 3, is 4. The answer is 2, is 3, is 4, because it usually occur from which you are having a rectum, you are having the sigmoid colon, you are descending colon. The vagus nerve is up to proximal 2/3, from distal 1/3, and this whole region is covered by H2, H3, H4. Scenario of Duchenne muscular dystrophy and mode of inheritance X-linked recessive. P53 is a tumor suppressor gene. When it is absent or mutated, it may indicate if this is a cell and it is going to die. So there is a programmed cell death. This is called apoptosis. Now, who causes apoptosis? This is P53. If there is mutation in this or this is not working, there is no apoptosis. If there is no apoptosis, there is prolonged survival. There is prolonged survival. There is prolonged survival. And if there is prolonged survival, there is increased risk of changing into malignancy, cancer. So if there is a mutation, P54 quickly causes apoptosis of this cell. If there is no P450, it will increase survival and lead to cancer. Over here, there will be cell survival is the right answer. Regarding skeletal muscle, which one is the right answer? So origin is mobile? No. Origin is usually fixed. Insertion is fixed? No. Usually insertion is mobile. Belly is fleshy throughout. The fleshy portion of the skeletal muscle is called belly. This portion is called belly. So this is fleshy throughout. Aponeurosis is fibrous. Again, this is also right. Aponeurosis is fibrous. But that may be fibroelastic. There may be some elasticity. Ligaments are round and fibrous? No. That is the tendon are round and fibrous. So over here there may be the tie between C and D. Pick the C more than D. If there is no C, then D. 5-hydroxyandoleacetic acid in urine is a carcinoid tumor. For carcinoid tumor, they usually give a scenario: a patient is having diarrhea, flushing, and he is having a cardiac murmur and weight loss. The answer is carcinoid tumor. The answer is carcinoid tumor. Coming next, area most commonly associated with Parkinson's disease is, now this is actually the substantia nigra. This is actually the substantia nigra. Mainly this is substantia nigra. So you are having dopamine and you are having acetylcholine. So what happened in the Parkinson? Dopamine goes down, acetylcholine goes up. So there is the imbalance between the two. There is imbalance between the two. And if dopamine increases and the acetylcholine goes down, this is called psychosis. So there is another MCQ. What is opposite of Parkinson? The answer is psychosis. The answer is psychosis. This dopamine is released mainly by this substantia nigra. Bronchopulmonary segment. Now again focus on the tertiary bronchus. It is not bronchioles. So they will confuse you that it is supplied by tertiary bronchioles. No, that is not the right answer. And on the right side and on the left side, both there are 10 segments. Each segment has its own arterial blood supply, and each is a independent unit. Patient with atrial fibrillation died show. Now atrial fibrillation, if there is a death due to atrial fibrillation, this is usually due to the stroke, and then so there is embolism. Usually there is embolism. Patient chief complaining of tingling sensation post thyroidectomy. Now when you remove thyroid, usually there is a high probability that you also remove parathyroid. So if you have removed the parathyroid, there will be no parathyroid hormone. If no parathyroid hormone, there will be no activation of vitamin D, because the calcidiol is converted into the calcitriol in kidney by PTH. If no PTH, so there is no conversion. If there is no conversion, there will be decreased calcium and decreased phosphate both. So this lead to tetany. So they will also give you an option of tetanus. So you have आपने फोकस करना है कि ये टेटनी है, टेटनस नहीं है, टेटनी. Focus on this, tetany. Now after thyroidectomy, which drug has the most significant effect? OPDs में हम देखते हैं लोग विटामिन डी देते हैं, उसकी कन्वर्जन नहीं हो रही. विटामिन डी नहीं, उसमें एक्टिव फॉर्म आपने देना है. कौन सा एक्टिव? अल्फा कैल्सिडॉल आपने देना है. बिकॉज आपके पास पीटीएच नहीं है, तो अगर आप विटामिन डी दे भी तो उसकी एक्टिवेशन तो नहीं होती. अल्फा कैल्सिडॉल ऑलरेडी एक्टिवेटेड फॉर्म ऑफ विटामिन डी है जो किडनी में होती है. सो यू हैव टू गिव अल्फा कैल्सिडॉल. दिस इज़ द एक्टिवेटेड फॉर्म ऑफ विटामिन डी, और ये वो एक्टिवेटेड फॉर्म है जो पीटीएच ने ऑलरेडी इस पर काम किया है. तो अगर आपकी बॉडी में पीटीएच नहीं है तो अल्फा कैल्सिडॉल विल टेक केयर ऑफ दैट. Person come to the physician with diagnosed case of diabetes mellitus. He suffers from the infected foot. Greenish pus is for the pseudomonas. Coming toward this 60-year-old business lived for 40 years in Egypt. Now person is living in Egypt and he is having cystoscopy was done and the biopsy specimen showed transitional cell carcinoma. Urine examination showed pear-shaped ova with large. Now this is a clear-cut scenario. This is a schistosoma hematobium, a clear-cut scenario causing the bladder CR. Organophosphate poisoning. Now this is the MCQ I would like to discuss. This is that MCQ I would like to discuss. Best initial. A patient come to you with organophosphate poisoning. Best initial is always atropine. Best initial is always atropine. Most specific. The answer is prelidoxime. Most specific prelidoxime. If asked about only antidote, the answer is prelidoxime. The answer is prelidoxime. Now I will give you another scenario. Young patient with organophosphate poisoning, and the person is having cholinomimetic effect, lacrimation, pinpoint pupils, salivation, bronchoria, and the patient is having skeletal muscle weakness. Now focus on this scenario. The patient is having muscle weakness. Which will you give, atropine or prelidoxime? The answer is prelidoxime. Giving you the reason. On the skeletal muscle, you are having acetylcholine receptors, but these are not muscarinic cholinergic receptor. These are nicotinic receptors. And the atropine, it cannot work on the nicotinic receptors. If it cannot work on the nicotinic receptors, of course you are having here increased acetylcholine. The mechanism for muscle weakness in organophosphate poisoning is the same as we discussed in Corinergic Crisis. There is down regulation of receptors. So you are having increased acetylcholine and you are having nicotinic receptor. Do you think atropine can work on this nicotinic receptor and reverse this muscle weakness? The answer is no. So you have to give the drug. You have to give the pralidoxime. You have to give the drug pralidoxime to reverse the weakness. Pralidoxime, what does it do? The pralidoxime, it activates acetylcholine esterase enzyme. It activates acetylcholine esterase enzyme. When it is activated, it would cause the destruction of acetylcholine, the active form into inactive form. So there will be decreased acetylcholine. Whenever there is decreased acetylcholine, there will be upregulation in the skeletal muscle, and that weakness will be improved. So atropine can reverse all the thing except the muscle weakness. For the muscle, pralidoxime can reverse all the thing, muscle weakness along with all the cholinergic symptoms that the person is having. The organophosphate poisoning. What is the mechanism of action of organophosphate poisoning? It inhibits the acetylcholine esterase. So if it is inhibited, it cannot degrade the acetylcholine. जब acetylcholine नहीं मरेगा तो acetylcholine ज़्यादा होगी. जब acetylcholine inactivate नहीं होगा तो ये ज़्यादा होगी. जब ये ज़्यादा होगी तो पर्सन को कोलिनर्जिक सिम्टम्स होंगे पूरे बॉडी में. लेकिन कोलिनर्जिक सिम्टम्स स्केलेटल मसल में क्या होती है? वीकनेस होती है, और वो वीकनेस एट्रोपिन रिवर्स नहीं कर सकता. बता दिया कि निकोटिनिक रिसेप्टर होते हैं, उधर निकोटिनिक कोलिनर्जिक होते हैं, मस्करनिक नहीं होते. तो उसके लिए आपने प्रोडोक्साइम देते हैं. प्रोडोक्साइम क्या करता है? ये इस एंजाइम को एक्टिवेट करता है. जब ये इस एंजाइम को एक्टिवेट करता है तो क्या हो जाता है? एसिटाइलकोलिन आपका मर जाता है. नेक्स्ट, पियोक्रोमोसाइटोमा बिफोर सर्जरी मेडिकेशन. नाउ द पियोक्रोमोसाइटोमा, it causes increased release of noradrenaline, norepinephrine and epinephrine. So if this is your blood vessel, you are having both the alpha receptors and the beta receptors. The alpha receptors and the beta receptors, these are actually the beta 2 receptors and alpha 1 receptors. So what happens if you give the beta blocker? If you give only the beta blocker, let's suppose I have blocked the beta blocker, I have the beta receptor, and the beta, if the beta receptor is stimulated on the blood vessel, what will be the effect? If it is stimulated, it will cause vasodilation. If these are blocked, it would usually cause vasoconstriction. The beta 2, if they are blocked, if they cause vasoconstriction. That is the reason that non-selective beta blocker cause peripheral arterial disease, and that is the reason you have not to give propranolol in a patient with peripheral arterial disease, because there is a more vasospasm. The alpha receptor, if they are stimulated, they cause vasoconstriction. The beta receptor, if they are stimulated, they cause vasodilation. The beta receptor, if they are blocked, they cause vasoconstriction, and that vasoconstriction is because of the alpha receptors, because you are having noradrenaline acting on both the alpha receptors and the beta receptors. But the beta receptors, if they are blocked, so the alpha receptor, they are stimulated and cause vasoconstriction. So I'm covering more and more MCQs with this. Let's suppose this is your blood vessel. This is beta receptor and this is alpha. If you have blocked the beta receptors, so if the noradrenaline, the narrow ending, the sympathetic narrow ending, they send the signal to both. Can they stimulate beta receptor? No. Can they stimulate alpha receptor? Yes. So there will be vasospasm, there will be vasoconstriction if you block the beta receptor. But if you stimulate beta receptor, that will cause vasodilation. So if a person is having piyochromocytoma, and this is blood vessel, and you give only beta blocker, so there will be severe vasospasm, and there will be hypertensive crisis. So first you have to cover the alpha receptors. First, block the alpha receptors. If the alpha receptors are blocked, then give the beta blocker. Then give the beta blocker. Alone beta blocker would worsen the condition. So आपने alpha blocker भी देने हैं और beta blocker भी देने हैं. The reason I discussed. PR interval shows AV node conduction. P wave, QRS, T wave. The PR interval, this thing, it shows the AV node conduction. It shows the AV node conduction. If the PR interval is prolonged like this, what does it mean? The AV node conduction is decreased. If the conduction is decreased, it will become prolonged. Or conduction is decreased. Conduction is decreased, but conduction time, that is increased. The conduction time across the AV node, that is increased in prolonged PR interval. So you have to focus on these things. The conduction is actually decreased, but the timing is actually increased. Anterior relation of hilum of right kidney, the second part of the duodenum. Patient had MI 8 days back, collapsed suddenly. What is the cause? So I will discuss this separately, the post-MI complication, and usually they give a scenario from it, and there is a table in first aid after 24 hours, what will happen after 1 to 3 days, then after first week, then the second week and third week, and from this they will give you 2 to 3 MCQ. So over here there's a rupture of the myocardium and there is a cardiac tamponade. The A is the right answer. Patient is having diarrhea, feces have donut-shaped cyst, the cryptosporidia. 35-year-old tall male has hypertension for the first time and he dies. His autopsy showed ruptured aneurysm. There is deficiency of media at the site of rupture. Now, the whole scenario is the patient is having hypertension for the first time. The patient is having hypertension for the first time and he is tall and there is medial degeneration. The answer is aortic dissection. But what is the diagnosis of this case? Marfan syndrome. If they ask about which disease the person was having, Marfan syndrome. What is the cause of death? Aortic dissection. What is the cause of death? Aortic dissection. Main difference between primary and secondary intentional wound healing. Wound contraction. There is wound contraction, parasympathetic component as in pelvic spine, brush border, proximal convoluted tubule. It increases the surface area because the proximal tubule has maximum absorption, so it has more brush border to absorb more and more things. Regarding Clostridium, spore forming. If a patient is unable to hear high frequency sound, the damage to the basiliary brain is close to. Now this is very important. You are having this ear. So remember HB, hemoglobin. High frequency occur across the base. High frequency across the base. The low frequency would occur across the apex. Simple as that. High frequency the base, low apex. The intermediate frequency would occur in between the base and the apex. So the oval window, it lies close to the base. Is the base of the cochlea is located near the oval window? So this is the right answer. Muscle arising from femur having role in stability of the knee joint. Now stability of the knee joint and stability of the patella, these two are ये दो अलग चीज़ें हैं. अगर ये पूछे कि नी जॉइंट की स्टेबिलिटी तो वास्टस लैटरलिस और पेटिला का तो वास्टस मीडियलिस. Coming next, girls with type 1 diabetes having mostly hyperglycemia in the morning. Now morning hyperglycemia, this is another MCQ I quoting. What is the best next step? The answer is check 1 a.m. or 2 a.m. sugar level. If that sugar level is low, it means the morning hyperglycemia was due to high nocturnal dose of insulin. What happens if you at bedtime, if you give high dose of insulin in the night around 1 to 2 or 3 a.m., what happens? The sugar level goes down. If the sugar level goes down, there is the release of counter regulatory hormones such as growth hormone, norepinephrine, epinephrine, that causes increase in sugar in the morning. They causes increase in sugar in the morning. And if the 2 a.m. or 3 a.m. sugar is high, it means your nocturnal dose was low. Your nocturnal dose was low. Your nocturnal dose was low. So there are two phenomena, dawn phenomena and Samoji phenomena. In dawn phenomena, your nocturnal dose is down. Your nocturnal dose is low. So you have to increase the dose. In Samoji phenomena, your nocturnal dose was high, so you have to decrease the dose. So if there is a morning hyperglycemia, this is also clinically relevant in the ward. We have to check for that. 1 to 3 a.m. or 1 to 2 a.m. you check the blood sugar. If that is low and in the morning there is hyperglycemia, so this is Samoji phenomena, and you have to decrease the bedtime insulin level by 2 to 4 units. And if that is high at this time, it means that the nocturnal dose was down phenomena, and you have to increase the bedtime dosage. Well, I will make another video for glycemic control in ward, just for the clinical purposes, not for the Fcps part first, because there are a lot of confusion which insulin to give, when to start the oral treatment, when to start the insulin, how to give insulin in the CLD patient, how to give insulin in the CKD patient, the poor glycemic control. What are you supposed to do? You are giving maximum insulin, but there is no response. In that condition, what are the other causes that you should look? The basic principle is that, but I would say only one thing: unless your fasting sugar is controlled, you cannot control the random sugar. This is the rule of thumb. If you control the fasting, you can control the random. If your fasting is not controlled, random cannot be controlled. Just remember that. Over here the answer is regular insulin and intermediate insulin twice a day. 70-30 in BD, you give insulin N and insulin R. Insulin N in BD and R in TDS. Penile erection tissue type of receptor, muscarinic, cholinergic. Total body water can be calculated by antipyrine. That can be calculated by antipyrine. Coming next, medullary branch of vertebral damage on the right side. Which of the following will result? Loss of hypoglossal nerve function on the same side. This is, suppose, the tongue of the patient. Let's suppose this is my tongue, and you are looking from the top. This is my tongue, and I'm looking. Let's suppose you are standing on my head side. These are my ears, so that you can see. And this is my front. This is my right side, and this is my left side. So when I protrude the tongue, there are two forces: the right side force and the left side force. They must be equal. If this force, the right side force, is decreased, the tongue would deviate to this side. If the left side force is decreased, the tongue would deviate to this side. So this is very simple. If you are having lesion on the right side, it will go to this side. If on the left side, it will go to this side. So it causes the ipsilateral movement. So that is very simple. Similarly, for uvula or soft palate, if this is the soft palate and this is supplied by muscles, normally both muscles have equal force and causes elevation in the midline. So if the force on this side is decreased, if it is decreased on the, let's suppose say that this is the right side and I'm looking to the patient. If force on this side is decreased due to lesion on this side, it will deviate to the opposite side. So it will move toward the contralateral sides. This is simple physics. Coming next, femoral hernia descends posterior to the inguinal ligament. Well, I will more focus on the physiological MCQ, the concept I will give. Patient from Sibbi, Balochistan, and there there are a lot of sand, fly, kalazar. Hyperkalemia is induced by strenuous exercise. Insulin causes hypokalemia. Do you know how insulin causes hypokalemia? It runs sodium potassium ATPase. It runs sodium potassium ATPase and it moves the potassium inside. It moves the potassium inside. Which other hormone runs the sodium potassium ATPase? Thyroxine. That's why in hypothyroidism this pump is not that much activated, so the sodium cannot comes out, so that leads to hyponatremia. It is one of the mechanism of how hypothyroidism causes hyponatremia, and this is one of the mechanism how decreased insulin causes hyperkalemia. Coming next, which protein is defective in diffuse muscular dystrophy? Dystrophin, cause of edema in known case of ischemic heart disease and hypertension. The answer is increased hydrostatic pressure because of the retention of water and salt. Which one of the following is respiratory adenovirus? Adenovirus. Grading of a tumor means differentiation. Staging of a tumor means invasion or metastasis. Baby defecation after a feed is due to gastrocolic reflex. And baby vomiting, they will confuse you. Vomiting, so if you preoccupy your mind with gastrocolic reflex and you are sitting an exam, due to the tension and stress, you would not pay attention to the stem and you would read it as baby vomiting and you study it as baby defecate after feed is due to, and the MCQ actually is baby vomit after feed, so you will pick the gastrocolic and you would mistake. तो इसके मार्क्स आपसे कट जाएंगे. So you have to study the stem carefully. Open your eyes and mind both. Increased ventilatory rate during exercise is due to proprioceptors, that is collateral signal from high centers. Cause of hyperkalemia, strenuous exercise. Which of the following triggers the onset of labor in fetus? That is ACTH in the fetus. If there is not an option, then cortisol of the fetus. Which of the following is the greatest effect on serum osmolarity? That is vasopressin, also called the ADH. So if there is a high osmolarity, so the ADH will retain water so that the osmolarity is resolved. What will increase in Graves? So T3 and T4 goes up and T6 goes down. I would say another thing. In SIADH, if you give normal saline, what will happen to hyponatremia? The answer is worsen. Hyponatremia worsen in SIADH if you give normal saline. You have to give hypertonic saline, not isotonic. Subclavian, usually in hyponatremia, you can give normal saline in hyponatremia, but the only condition in which you are not supposed to give normal saline is SIADH, and the reason is that in SIADH the urine osmolarity is sky high. So if the urine osmolarity is already high, so whatever volume you are giving to the patient, that will increase the free water content that will not be excreted because the urine osmolarity is already high. Subclavian and internal jugular joints to form brachiocephalic. Coming next, during hyperthyroidism, high cardiac output failure, because the cardiac output is equal to heart rate into stroke volume. What happens in the hyperthyroidism? The heart rate is increased, stroke volume also goes up, cardiac output goes up. The second thing is in the periphery, the metabolism is increased. So if the metabolism is increased, there are vasodilatory substances produced that cause vasodilation and that increases the venous return. If the venous return is increased, that will again increase the cardiac output. PR interval is prolonged due to AV nodal delay. Apex of the heart is supplied by marginal artery. If the question says only apex, marginal artery. If the question says apex with interior wall, then LAD. Level of conus medullaris. Conus medullaris is the lower portion of spinal cord. L1. Old female with osteoporosis and hypertension leading to thiazide, because thiazide retain the calcium. What other condition in which we are supposed to give thiazide and hypertension? The answer is renal stone, because the calcium is absorbed, so the calcium will not come down, so there will be no precipitation of calcium, there will be no stone formation. So thiazide prevents the stone formation, point number 1. Point number 2, it increases the serum calcium and it helps in the osteoporosis. Tall stature, underdeveloped testes, gynecomastia, and double XY genotype. The answer is Klinefelter syndrome. Delayed action of insulin is lipogenesis. Most immediate is entry of glucose and potassium to the cell, and intermediate action is protein synthesis. This is the right sequence. It is anabolic hormone. True about glycocalyx is carbohydrate moiety. Yes, they form the carbohydrate coating. Most potent stimulus for gastric acid secretion is protein, amino acid. If that is not in the option, then gastrin. Then gastrin. And if gastrin is not in the option, then histamine. Then histamine. But most potent endogenous stimulus, endogenous gastrin. If that is not in the option, then histamine. Most potent exogenous stimulus, that is protein, amino acid. Type of anemia in chronic renal failure is normocytic, normochromic. But if the question says the patient is only on erythropoietin, what anemia do you suspect? Microcytic hypochromic, that is iron deficiency anemia, because you are supposed to give erythropoietin and iron both, because for increased RBC production you need the ingredients. If you are deficient in ingredients, it will lead to microcytic hypochromic anemia due to iron deficiency anemia. Blood supply of middle esophagus, already discussed, that is descending thoracic aorta. The inferior thyroid artery, it supplies blood supply to the, it provides blood supply to the upper third, and left gastric to the lower third, descending thoracic aorta to the middle part. Typical neuron feature is discussed. In upper motor neuron lesion, there are accelerated reflexes. Chromosome with 2 perichromatid are seen in the prophase. Which of the following is more specific for GGT? A rich source of vitamin K is green vegetables. Antithyroid drug in 5th month, there is methimazole. In first trimester, you propyl thiouracil. Dopaminergic neurons are most abundant in substantia nigra. The difference in carbohydrate metabolism in pregnant and non-pregnant female is postprandial hypoglycemia. So these are the one-liners, but these are all MCQ that are repeating, and again you have not to mess them. But there were some other MCQ that were left on this page. This page, amoebic liver abscess is diagnosed by serology. That is the right answer. A patient with hypoxia having PO2 16, HB15, no history of poisoning. If there is no history of poisoning and the patient HB is normal and still he is having low oxygen, the answer is hypoxic hypoxia. Because hypoxic hypoxia means in environment there was decreased oxygen, so it may be due to high altitude. Anemic hypoxia is usually caused due to carbon monoxide poisoning, because let's suppose this hemoglobin, if it attaches to the hemoglobin, it causes the increased affinity for other oxygen molecule, and they are tightly bound to the hemoglobin molecule. If they are tightly bound to the hemoglobin molecule, they cannot be released, so it causes the lift shift of hemoglobin dissociation curve, and it causes anemic hypoxia. And the oxygen concentration or the oxygen tension in the blood is normal. That is another thing. Oxygen concentration is normal. Stagnant hypoxia is caused due to infarction. If there is myocardial infarction, it cannot contract. So what happens? The blood it lies in the vessel. It cannot move away. So it lies in the vessel. So all oxygen is consumed. There is no further oxygen coming down. So it causes stagnant hypoxia. So infarction causes stagnant hypoxia, but the stagnant hypoxia causes polycythemia. How? Because if there is low blood flow to the kidneys, normally the kidney monitor the oxygen in the blood. If there is low blood flow to the kidney, it presumes there is a decreased oxygen, so it releases erythropoietin. So it leads to polycythemia. There I will relate another MCQ. A patient comes to you. There was a patient comes to you, and he is in distress. You check oxygen saturation with pulse oximeter. It is 97. The PO2, that is also normal. But the patient is in distress. What can be the cause? Now, the question I like to ask over here is, what is the condition in which the pulse oximeter gave you the normal oxygen saturation, but when you do ABGs on machine, the oxygen saturation and the oxygen is down? The answer is methemoglobinemia. The methemoglobinemia actually gives you normal oxygen on the pulse oximeter, but machine can tell you the right saturation. Point number one. Point number two, in carbon monoxide poisoning, the same thing happens. The pulse oximeter cannot differentiate between oxygen and the carbon monoxide. Well, over here I will make to clear another MCQ. One is the carboxy hemoglobin, the other is carbaminohemoglobin. Carbaminohemoglobin. What is the difference between the two? Carboxy hemoglobin means carbon monoxide is attached to the hemoglobin. Carbaminohemoglobin means CO2 is combined with the hemoglobin. This is a normal phenomena. Do not confuse carbaminohemoglobin with the carboxy hemoglobin. Coming next, AFP is elevated in hepatocellular carcinoma. Which of the following has no muscular attachment? Talus. A 2-year-old child presented with thin mucoid discharge from an opening on the anterior border of sternocleidomastoid in the lower third. So this is actually that sinus. So if you are having pharyngeal arches, let's suppose these are the pharyngeal arches. If you are looking from the outside, this is cleft. This defect is called, this is usually not the defect, but this depression is called the cleft. If you are looking from the inside, so this pit is called pouch. From the inside they are called pouch, from the outside they are called cleft, and there is a mesenchymal portion. They are called arches. They are called the arches. So the first cleft gave rise to the otitis externa and the ear. The second, third, and fourth, they combine and degenerate. But if there is a problem with the degeneration with them, they form a sinus. So over here, this is the second, third, and fourth clefts. If they are not, you choose the second cleft. So with this, the paper 1 of medicine is completed. Is getting. Thank you for watching. Thank you for joining. Thank you for sharing.